Hi, everyone. My name is Dr. Colette Smart, and I'm a registered psychologist and psychology professor. I want to welcome you to this guide that talks about medical trauma, trauma informed practice, and why it's relevant to brain injury neurorehabilitation. I want to introduce myself and tell you a bit about the background of how this project came to be. So, I never set out to be a trauma therapist, but it was the thing that kept showing up in my clinical practice. So, my background is as a clinical neuropsychologist, and I have particular work and expertise in the area of cognitive rehabilitation. So, I've worked with many brain injury survivors, people who've had strokes, brain tumors, and many, many older adults, just to name a few groups. And apart from being a psychology professor and teaching and doing research, I've also had a private practice for many years where I provided psychotherapy and cognitive rehabilitation to some of the folks that I mentioned. And I just kept noticing that trauma was showing up in my practice, different types of trauma. And as you're going to learn about in this guide, PTSD or post traumatic stress disorder is actually more common than you think in the acquired brain injury population. Um, Certainly amongst people with traumatic brain injury and stroke and other major neurological diagnoses as well. So I'm using that term acquired brain injury a bit more expansively and inclusively. And so trauma can affect survivors, but it can also affect their loved ones as well. So there's research and clinical experience that being a family member or a caregiver watching somebody going through a major life altering event like a brain injury or a stroke can be traumatic for them as well. So, some of the trauma that I observed was what we would classify as medical PTSD. So, the medical event itself was a traumatic stressor, and that caused these traumatic stress responses. However, for some other people, aside from that, they might also be dealing with something that we call complex PTSD or complex trauma. So that would be if you were someone who had an abusive or neglectful childhood, if you have a history of intimate partner violence or any kind of coercion or abuse in close relationships, if you're a refugee or you've been subject to forced migration or you've been in any kind of abusive group or even abusive or bullying workplace, those are some of the conditions that can lead to complex trauma as well. And sometimes people would come in with the brain injury and that background. But also, we know, for example, especially if you had childhood mistreatment, abuse, or neglect, it does seem to increase the risk for things like stroke and cardiac events when we're older in life. And what was interesting was most of my patients didn't know that they were dealing with some kind of medical trauma. And so, like I say, I never set out to be a trauma therapist, but we sort of discovered together that trauma was a big piece of the puzzle and that we really needed to address that. And when we started to take a trauma informed approach to their care, everything made a lot more sense. Now, one of the things I would often hear from survivors is, why did none of my other practitioners bring this up to me? None of my other healthcare practitioners bring this up. Did they not see it? Did they not care? You know, what was happening? But I know from being in conversation with a lot of other providers and practitioners that many times they were aware that there was some kind of trauma at play, but there was some fear and concern about how to bring it up because they didn't want to cause more harm. And this is especially a concern for people who are not actually mental health providers. So it's different for someone like myself, who is a mental health provider, who definitely feels like that conversation is part of my scope of practice. But if you're working in another healthcare or medical field, you might feel like that's beyond your scope of practice, and there's some appropriate concern about not stepping outside of that and potentially causing harm. So it meant that survivors were kind of in the dark about what was happening, and then providers were reticent to sometimes step in because they didn't want to cause more harm. So it seemed to me we needed to find a way to work together to kind of bridge this divide and start to open up the conversation about trauma. So this brings us to trauma-informed practice. So trauma-informed practice, or what I abbreviate to TIP, TIP, trauma-informed practice. So it's a movement in healthcare that's been going on for quite some time now. And really the idea is, instead of directly talking about trauma and having people reflect on or discuss their trauma, there's just kind of an acknowledgement and a recognition and awareness that trauma in certain contexts is quite common. And so if we can just set up the environment in a way that's going to be supportive and helpful to people with trauma, it's going to support everyone, because the elements of trauma-informed practice can be supportive to anyone, whether you have that trauma background or not. And you'll learn a lot more in this guide about what those elements of TIP are. So we see TIP in a lot of different areas of healthcare, but one area that it might not have made its way into as much is neurorehabilitation. So neurorehabilitation refers to the therapeutic approaches we use to help survivors overcome and recover from their brain injuries. So I am definitely what I would call a scientist practitioner. That's how I was trained. That's how I am now as a psychologist. And so what that means is my clinical work influences the research that I do, and then I bring my research findings to my clinical practice. So seeing this for years in my clinical practice, I got the idea that it would be really helpful to do a research study on this so we could learn more and figure out how to better have those conversations. So we decided to convene a team of experts who would work together and figure out how we could bring TIP into the neurorehabilitation context. So I oversaw the study as a principal investigator, but I worked in close collaboration with my colleague, Dr. Sarah McCown, who is a pediatric neuropsychologist and another psychology professor that works alongside me. So she does similar work to what I do, but I work with adults and she works with children. We felt it'd be really important to capture that whole spectrum from kids up through adults. And she had worked for many years as well in a clinical practice with kids and families, and had observed some of the same things that I had in terms of issues with trauma, speaking about trauma, and being able to have those open conversations. So there was Dr. McCown and myself. We had some students that worked with us here at the university, and then we also recruited a group of healthcare professionals from the main rehabilitation hospital here on Vancouver Island. And the process we went through is called a Delphi study. And this is an expert consensus study that's used in healthcare, where people who have expertise on a certain subject come together in a really kind of structured dialogue and figure out how can we make some improvement in this aspect of healthcare. So there's many Delphi studies happen all the time, but what was really unique about our Delphi study and our approach was we felt it was essential to actually have survivors themselves and family members and caregivers be represented as experts on our panel, because at the end of the day, survivors are experts on their own experience. So we had a team of what we call patient partners. So these are people with lived experience who volunteer to be part of our research team and contribute their knowledge and expertise. So we worked together for a year. There was 16 of us, I believe. We had a big group. And we had this really structured process that we went through, and we created these guidelines, TIP guidelines for neurorehabilitation. And we submitted and had published a peer-reviewed journal manuscript in the journal Rehabilitation Psychology, and that came out in early 2025. And so the purpose of this website, because this project was always designed with a practical purpose in mind. So we didn't want to just publish the article and call it a day. We wanted this to actually be useful. So we decided to create this website as a knowledge translation portal that could help the guidelines that we created actually come to life with easable, accessible information, videos for patients, for families and caregivers, but also for professionals, so that we can all figure out ways to work more effectively together. So the actual guidelines will be available as a downloadable PDF. And if you're a provider watching this, I really would encourage you to bring this to your workplace and see if you can do some work to implement some of these guidelines. And of course, we'd ask you that you give us credit for our work for that. And then for patients and families, hopefully there's some pieces in here that can help you advocate on your behalf in case you're in a situation where you're the person who's going to initiate that conversation. So it was my absolute pleasure to lead this project. I also want to give a special thanks to Charlene Shako, who was my wonderful student who worked to create this resource here on Canva, and she did a great job really bringing the material to life on this website. So I hope this will be of benefit to you.